So now is the time to give us your time. Um, and from sure, Neil Lynch is a consultant radiologist at Stepping Hill. He was a consultant before I became a consultant, judging from the comparison between the amount of white hair we both have. But he's been a fantastic colleague, and we work very closely together and do our interventional procedures together as well, especially the percutaneous stone surgery. We're usually in theatre together almost every Thursday for the last 19 years.
Oh, good Lord. Okay, Neil, can you hear me now?
Yeah, much better now. I've got you on my my headphones.
Wonderful.
Yeah.
Thank you very much for agreeing to do this. 19 years with Banji, I'm sure that the stress you must have undergone must be enormous. But thank you very much for your support for the group, and thank you very much for agreeing to do this for our trainees.
No problem.
Looking forward to it.
Yeah, well, Banji, we first met Banji in Dublin in 1991 or 2, wasn't it?
That's correct.
When Banji was an SHO and I was the Reg in radiology.
Oh, good Lord. So it's been quite a
Dublin.
long time.
Yeah.
In Dublin, Ireland. Yeah.
So a long time ago.
Yeah, it's a long time ago.
I'm just seeing everything's okay. I think everything is okay. Everything looks okay, Banj, doesn't it? I think it's going to be.
It looks good at this end.
Yeah.
The only thing is perhaps changing it to the slideshow.
Yeah,
from
slideshow from the beginning. Yeah, I'll do that.
Yeah.
That one.
Yeah.
Yeah,
There we go. Yeah.
And that's
the
brilliant.
one.
Okay, so we're just waiting for the guys. The first person has logged on.
To log on, yeah, no problem.
To log on, and then we'll take it from there.
That's okay. Right here. I'm just checking. I'm still on call, so I'm just checking my. Let's just see. There's nothing else happening, I hope.
So are you on call? Are you as a general radiologist rather than urological radiologist?
Yes, general. We've 15 radiologists, but
Okay.
three of us do most radiology. But actually, I have other colleagues. We've got about how many? We've got 5 or 6 of us do PC. We'll do nephrostomies. You know, it's quite good. Compared to every other, we're better than every other hospital in the region, probably.
Okay.
As far as that's concerned.
I think. Do you think that's because of the urology?
Yes,
history?
I do. I think so.
Yeah.
I also think it's the Department of Urology as well, because all my colleagues get on with the urologists, and we don't all get on with other specialties that I won't name. But generally the surgeons, radiologists tend to get on with surgeons, and I think, I'm not sure exactly why. I think you need us, while the physicians don't. The physicians just look at a report and don't have no idea who's written it. While the surgeons pay very great attention to who's written the report.
I agree with that, because I spend probably about 3. I'm in radiology department probably about 3 out of every 5 days.
Yeah.
To have a look at it and see things.
Yeah.
And I tell
Absolutely,
my and I tell my juniors, look, until you see what they're talking about, that's what makes it easier.
Yeah. So Neil Funshaw is a general surgeon.
Right. Well, I've just had Natasha Henley, one of our upper GI surgeons, come in, and we reviewed a scan here just now. So Natasha is on call. She's a consultant on call today, so for general surgery. So she came in to review a couple of cases with me.
Yeah, that's great. I think it's usually very helpful to see this, what people are talking about.
I try and encourage the juniors to do it as well. Some of the physicians just they don't know who. I don't know who they are. They don't know who I am. I know who all the surgeons are. You know. No, we know very well all the general surgeons, all the urologists, all the orthopods. Well, actually, some of the some of the new orthopods, I don't know who they are. We have 20. We've an enormous number of them.
Well, isn't that the partly because they're actually able to look at their own radiology quite well?
Yeah, we actually have a lot of musculoskeletal radiologists as well, because we've got so many surgeons. So they tend to really our musculoskeletal guys are really into it, and they give them a very good service, so they get on very well together. So quite often they just won't ask us. They'll ring one of their pals to have a quick look, and because of the PACS system, which has changed everything really, you can look at a film from anywhere, really. We can look at films
Absolutely.
from home. You know,
Yeah,
it's just
absolutely.
fantastic, the PACS.
Yeah.
It's made a massive difference to radiology, and I think to surgery as well. You can look at the same picture from different sites, which I think is just amazing.
Yeah,
when you consider,
it has, yeah.
You know, it's revolutionized everything, really. So yeah, so it's been good. So, you know, but we've changed. My job has changed enormously. Radiology is massive change since I qualified, anyway.
Yes.
And of course, I qualified with Banji, you know, with one of your, with one of the trades. Isn't he a transplant surgeon in Lagos?
Was that Tunde? Somebody, Tunde?
No, he's a bit older than me, actually.
It's okay.
Yeah.
Oh, Ben Shabanjo.
Banji, what's the guy? It's Shonabare.
Yes,
I was in college with him.
In Lagos.
Ayo
Shonibare.
Ayo,
heard about him. Yeah, I think he trained he did his undergraduate studies at the Royal College of Surgeons in Ireland. He's been in Lagos for many years, and he's part of the group that opened that big new hospital in Lekki, private hospital in Lekki, in this last year.
Okay.
Are you aware of that? Yeah, that one. I can't remember the name of it. But there's a big new private hospital on the Lekki Peninsula, and Ayo Shonibare is one of the owners or architects of that.
I see your pictures behind you, Banji. I've got my bicycle here, just I'm wobbling it. Cycled in again this morning.
No, I've not worked out how to put a nice background, so I just leave it as my study.
No, mine is, if you look behind me, that's one of our filing cabinets. That's all that is.
Funshaw is a big cyclist as well.
All right,
Yeah. I saw that's the first thing I think caught my eye when I saw your screen. Was a cycle behind you. Yes.
The bicycle, there it is. Yeah.
Yeah, that's very good.
It hasn't made me lose any weight though, Banj, has it? I'm still the wrong side.
As long as it keeps the heart active, that's what matters the most.
Yeah. I should have put up a picture of me. My cousin sent me pictures of me playing rugby back in in college days, about 1980 or something. Slightly different shape then.
Okay.
So the guys are a bit late. We still only got one person. I'll just.
It's 4:02 now. Hopefully they'll all join within the next 5 minutes.
Yeah. Vincent, can you get your colleagues to come up, please? Vincent, can you hear me?
Yeah, good evening, sir. I'll put a notice on that, sir.
Okay, can you do that, please?
Yes, sir. Thank you, sir.
So are these guys from Ibadan? Is that it?
That's
yes,
right.
they're all from Ibadan,
right.
yes.
Okay.
And they're all from Ibadan. Many of them would be wanted to specialize in urology.
Right.
But I think the vast majority are junior trainees who are doing surgery in general.
Yeah, I've tried to try and keep it that way to talk, because you can get very involved in the intricacies of your radiology, and I try to keep it very surgical, showing lots of pictures really. So hopefully they'll get something from it. But I'm doing really what we do, Banji, isn't it? It's what we do now.
Indeed, very practical, yeah.
It's what we do in Stepping Hill, and some equipment we don't have, some things we can't do. But that's the same for everywhere. Every hospital is like that. Most places, certainly in the UK anyway. We don't have vascular anymore. That's disappeared. There's only going to be one vascular centre in Greater Manchester. That's it. So if you need any vascular stuff done, it has to go there.
Yeah, that's that's the same thing everywhere now, isn't it?
Yeah.
We lost our vascular unit just before COVID, so late end of 2019, after having paid to build a totally new vascular theatre.
Wow.
State-of-the-art theatre and everything, because we were bidding for this, and then it came down to it, and they awarded it to a bigger hospital. It was a bigger hospital,
Yeah.
and then that theatre has been lying fallow now for almost 2 years.
They are really expensive, by the way.
Yeah, they are
really, really expensive.
Mm.
But no, we haven't had vascular. I used to do some vascular renal work, but it's at least 10 years to done any vascular stuff.
Okay.
So
I think a specialist interventional radiologist, particularly for the smaller hospital, is becoming a bit difficult.
well, what the college have changed their tune a bit. The radiology college, they were very keen on subspecialization, and they've suddenly realized that there's lots of hospitals out there with no intervention.
Absolutely.
So all our juniors are obliged to do intervention of some description. So we've suddenly got a lot more interest. Like for years, I would do intervention on my own with no registrars, because most of them aren't interested in intervention because it makes it more difficult. It's more work. Anybody who does intervention is more hassle. It's more challenging, and you just get more work. You're busier, and so. But now they're all keen to do it because they've been told to. They've got to. It's because of change. Just the fact that we need it. It's necessary everywhere. Every hospital needs some intervention.
Sorry, the people logging on, can you switch off your microphone, please? Okay, can you all switch on your micro? Can you switch off your microphone rather? Because there's a lot of interference coming up now. Yes, there is quite an awful lot of intervention that needs doing. And suddenly we particularly, I don't know what it is like in your place, we're now, for on-calls, we're now dependent on external people to do the on-calls.
No, I don't. We're not. No, but we're not. Never really. Do we ever? Maybe occasionally we have to transfer a patient, but very rarely. Almost all intervention we can do ourselves in-house. Occasionally, when I'm not on call, I'll get a call to do something. Very rare though, Banji, isn't it? It doesn't happen often. Maybe once a year, twice a year.
Yeah. Actually, what I'm talking about is actually just general radiology now.
Yeah, no, I'm saying that. No, we'll do drainages. Everybody, I think practically there's only one or two of my colleagues who won't do them. So
I think Neil, I think he's talking about the medical thing. You know, the reporting.
Oh yeah, we use that as well.
Yes, that's what I'm talking about, Banji.
We've got to use them. Yeah, we use them. We've got to use them. We can't cope with the. I mean, we did, just to show you, we did 119 CT scans yesterday.
Good Lord.
Yeah, we do. We have 5 CT scanners, and we just can't keep up with the massive increase in the amount of scanning being done. It's particularly from A&E, but lots of people invent new protocols which involve radiology, but they just don't tend to tell us until the protocol is established. And suddenly we're obliged to keep up with this protocol. Particularly A&E are always at that. They're always inventing some new protocol which has to be followed. So our A&E workload is enormous. And we are also a stroke center. That's an incredible amount of scanning done all night long for CT. So we don't have neuroradiologists, but we are a stroke center, which doesn't really make. Yeah, I know it doesn't seem to make much sense to me either. But there you go. But we are. What they've done in Manchester, they've divided the city into 3. So there's three hospitals do strokes. One of them being the main neurosurgical center. So we're at the south side stroke center. There's one on the north side of the city, and Hope takes the referrals.
Okay,
still,
No, I think you can make a start now.
All right, radio. Okay.
Thank you.
Right. Okay, should I introduce myself to all who are here? My name is Niall Lynch, and I'm a radiologist who works in Stockport with Stepping Hill with Banji Adiotu. And I'm an Irish graduate. That's an Irish radiology graduate, but I came to Manchester as a senior registrar. That tells you how old I am. And I first met Banji in Dublin when I was a registrar and he was an SHO in general surgery at your level. That was 1992, I think, but I came to Manchester in 1993. So I've been a consultant in Stepping Hill since 1996. So I do a lot of uroradiology, and we have a lot of uroradiology work in this hospital. How many? 10 urologists, Banji?
Yes, 10 urologists.
10 urologists. There's a lot of work. So I'm going to talk about your radiology, and I'm trying to pitch it to your level. So I'm just going to go through everything that we do. This isn't what you do, this is what we do. So it will be different, it will probably be different. So I'll start off with oh, what's happening to my screen? There we go. I'm divided into diagnostic and intervention. I'll talk mainly about diagnostics. We do like a bit of interventional chat, but it probably isn't that relevant to you, but it is very interesting for as far as I'm concerned. So anyway, diagnostic radiology, I've just listed what we do there. Plain films are going out to some extent. We're using them less and less and less. We don't use IVUs anymore, but I've listed it because they are a handy test. Ultrasound, CT, MR, and nuclear imaging. CT being the backbone of our department to some extent. So plain films, very good for stone disease. Not as good as we thought. When I trained, we were told that we could see about 90% of renal stones in plain films. It's actually about 50% if you're lucky. So it's still used for diagnosis, still used for follow-up, but we may change to CT only and abandon plain films for early stone disease. I'll tell you why later. Also, it's also very handy for certain other things. If you get your eye in bilharzia, diabetes calcification, etc., for various random chance effects, our plain film usage is dropping quickly. So this is an IVU. The last one done here, 2007. This is it. Yep, 2007, the last time we did an IVU. And this is medullary sponge kidney, lots of little stones. But there's still a good test. It's just we have better ones. It's really good for colic because you can see the difference in excretion. You can see a blockage, you can see dilatation of the calyces, hydronephrosis. It's quite good for anatomy. Not that good for anatomy, but quite good. It gives you some idea about differential function. It's dead useful in emergencies and when infrastructure fails. It's also very useful because most people can look at one, but radiologists, you need a radiologist to look at these. And this is the current test, which is a CT-KUB. And this is a different patient with medullary sponge kidneys. You get much more detail on a plain film plain CT-KUB. And you can see things like an obstructing stone. That's in the distal ureter as it crosses the iliac vessels. So ultrasound is our next sort of modality. Very handy, portable, relatively cheap, pretty reliable. And the trouble is, it's the right hand. It's quite dependent on the person doing it. But the machines are reliable. They're quite cheap now, and it's hard to break them. So it's quite good for anatomy. It's really good for scarring, and it's quite good for stones. It underestimates the size, but you can see big stones. Anything over 5 millimeters is usually visible. Under 5 millimeters, it isn't. And the reason is stones are bright. Stones live in the center of the kidney usually, and you can't see them in this fat. This is medullary fat. This is the same patient actually. There's 2 scans. So this is a normal. The top picture is a normal looking kidney with a normal looking darkish cortex with a bright center. The bottom picture is a hydronephrotic kidney with really badly scarred cortex. This stuff in the middle is probably pus. I'm not sure it comes across very well, but there's a parallel lines there, and that's a stent, which nobody can see but a radiologist really. But so they're pretty good it's a very handy test, ultrasound, very easy to do, not so easy to interpret, very easy to perform, but not so easy to interpret. Very handy for things like hydronephrosis, or scarring, and various other things such as masses. This is a tumor. This is a solid lump in the kidney. So lumps in the kidney, they look a bit like the kidney. They're isoechoic or hyperechoic. And if you turn on your Doppler scan, which most machines have now, it'll be like a Catherine wheel. There'll be a big splash of color because they've got tumors have increased blood flow. So the other things that you see much more often in kidneys are cysts. We're always seeing cysts in kidneys. They're really, really common. We start seeing them from people from the age of about 30 onwards. And this is a typical cyst. You can see how dark it is. And there's a couple of other things here which don't really come across that well on this picture actually. The posterior wall is always bright, and there's often a bright through transmission, sort of a band of high signal behind it. But you can see how well defined that is and how black it is, how dark it is. And if you look, that's the gallbladder. It's fluid. Fluid is really dark on ultrasound. These are blood vessels in the liver. So, the other thing is, ultrasound is handy for lots of things, but testicular cancer, it's fantastic. This is a testicular cancer. This is a normal testis on the right, and then here you can see it's absolutely crazy looking. It's completely disorganized, huge blood flow, testicular tumor, barn door, and most people, let's face it, can see that it's got to the stage now where these machines are so good that the patients look at this and ask me, is that my cancer? Because it looks so dramatically different. And these machines are relatively cheap. They've certainly come down a lot in price since I started. So your ultrasounds now, you get a good machine for, certainly in this country, you get a half decent machine for 20,000 quid, will get you a really good machine for 20,000 pounds. And you can actually buy them on the net yourself for about $5,000. You can buy a Chinese probe, which you can plug into your iPad. And apparently they're not that bad. So ultrasound, really handy, very portable. But this is our workhorse, the CT scanner. I wanted to show you sort of how they work. The inside of one. This is the type of scanner we have. This is a GE 64 size scanner, and you can see they've taken it apart. So to show you how it works, this is an X-ray tube over on this side, this triangular thing here, and it fires a fan beam across the gantry, and over here are the detectors, and you can see they get hot. Lots of fans to cool them down. 64 slices, 64 banks of detectors on this side. The patient lies in this trolley, and you whiz through here. This whole gantry spins at less than a second. So you can do a top to bottom CT scan in 30 seconds, less than that. It's really fast, and you get very good detail. It's a fantastic machine, really, in many ways, particularly for the sick patient. It's really good at showing anatomy. It's really good for colic. It's fantastic for stone assessment. You can work out size, density, all sorts of stuff. You can work out function. It's really good for looking at tumors. It's very good for staging tumors, and it's really good when things go wrong following surgery, and you can see things like abscesses or collections following surgery. So that's how it works. Basically, it's fairly simple engineering, just a big X-ray tube with a fan beam, and you slide through the middle of it, and it takes a helical acquisition, which is a huge volume of information, and then the CT computer divides it up whichever way you'd like. You want it to divide up. So this is what's happened in our hospital, which sort of reflects what's happened in the UK and where I come from, Ireland. The first CT scanner here in this hospital was 1994. The first CT scanner description was 1971, but they took a long time to become universal. It was certainly they became commercially available in the late 1970s. They became a little bit more common in the late 1980s, and by 1994, we were the last hospital in Greater Manchester to get a CT scanner. We got a multi-slice scanner, much better scanner, 9 years later. Then we had to get a second scanner 7 years after that. Now we've got 5 scanners. One is what's called a dual energy machine. So what's happening to them? They're much more reliable. They don't break down half as much as they used to. They're really becoming much, much cheaper, although our dual energy scanner is very expensive, but the scanners themselves are much cheaper, becoming much more available. The dose, which is really important, it used to be very high, is becoming lower and lower. One of my colleagues in the hospital near us has got a really good machine, and he's a physicist masquerading as a radiologist. They've developed an artificial intelligence system, and his CT KUBs have a lower dose than a KUB. So the dose is now lower. He can get a dose lower than a plain film, and the scans are really good quality. And we're going to try that with our new machine. And I've just briefly mentioned this, but what has helped or enabled this expansion is the development of computerized reporting service, or the computerized picture archiving systems, because the amount of imaging is enormous. Most scans have about 1,500 pictures. So you have to report them off a computer. You can't do it off a plain film. Too much information. You just get overwhelmed. So the PACS system has helped. And the CT wouldn't have worked really without this PACS service. This is just a brief slide showing off our brand new machine, which we've just installed, but I don't know how to work it yet. And it's this one over here. It's a dual energy machine, and it's got these are just three types of dual energy. Our one is this particular one, and the advantage is it detects stuff at 2 different energies, and it can do all sorts of fancy stuff. It can subtract one image from another, and we're going to use this for urology. It'll tell you the composition of a stone. It'll make a non-contrast study out of a contrast study. It's an amazing machine, quite expensive, but hopefully be very handy for urology. We just don't know how to work it yet. It's only just got in last week, so I haven't had any training on it yet. So one of the things I need to talk about is techniques. There's loads of different techniques for CT of the kidneys and bladder. So there isn't just one, there's loads of different ones. I've just listed the ones here. The most common one we would use, I suppose, would be the plain film with no contrast. That we're looking for stone. We sometimes have to use it in renal failure. The other one would be the CT urogram, where we always do an excretory phase or a urographic phase examination. And this will be our commonest type of scan. There's loads of different ones for kidney, for various different kidney masses. We'd also use different ones for bladder masses, and we use different for adrenals and for renal angiograms. It's all different. You need to talk to your radiologist about these. It's becoming really quite complicated, CT, the various different techniques. Just to show you different techniques, this is, on the left is our plain film coronal image. On the right is a urogram. You may notice there's lots of nice contrast in the cortex. There's also loads of contrast in the collecting system and in the bladder and in that ureter. And what we've done is we've cheated a bit. We've given contrast. We've also given furosemide, and we've given contrast twice. So we get contrast everywhere, all through the system. Really nice scan. And with our, we just do 2. We just do a non-contrast and a post-contrast. With our new machine, we'll be able to just do this and subtract one thing from the other and make a non-contrast scan. I'm not sure how we're going to do it, but it can do that apparently. And this would be the commonest type of scan we do. Just to show you how important it is, this is a transfer from a different hospital to us for PCNL, removal of stone, and this is their scan. It is the same patient. You might note that the liver, the odd-looking liver, and this is their scan with contrast. We didn't have a pre-contrast, so we didn't. What's what? Well, we did a scan. We gave furosemide, and you can see we've made everything really, really dilute, and we've outlined the stones, and we've come to the conclusion this would be a very difficult PCNL because how are you going to get around this bend? So very useful for planning surgery. And so this is how we cheat and we get around the physiology of the body with our different systems and different techniques. So just to go through a couple of scans, what we generally see. This is a typical renal cell cancer pre-contrast. You can't really see much post-contrast. Well-defined mass. This is a solid mass, probably a renal cell cancer. About 80% of these solid masses are renal cell cancers. So that would be discussed at our MDT, and the decision made would be what to do with that, to either remove it, take a biopsy, or observe it. It's 2.5 centimeters in size. And that's typically the sort of thing we see, usually by the by, usually because we're doing a scan for something completely different. So, but renal cell cancers come in different types and different nastiness. Here's another cancer. It's a bigger cancer with partially cystic, and this cancer is invading most of the kidney. And this patient needs a nephrectomy. You may notice this was done for left-sided renal colic, and he has a stone in his proximal left ureter, but actually a completely hidden, silent, big renal cell cancer, which needs nephrectomy. And just to show you other problems with renal cell cancers, here's another renal cell cancer, and here's a metastasis. So this cannot be operated on, and in this case, I would be asked to do a renal biopsy of this mass, so the patient can have various chemo or immunotherapies. This is just to show you an adrenal scan. This is called a washout scan, where we scan 3 times. And we work out how quickly the contrast goes in and goes out of the adrenal lump. And depending on that, we can decide whether there's a tumor there or not. In this case, this is a metastasis from a renal cell cancer. The left kidney has been removed 15 years ago. But this is a recurrence that's turned out to be a renal cell cancer. What should happen with a typical simple little adenoma is the content should wash out really quickly, and it just doesn't. It hangs around. Therefore, it's probably a metastasis or possibly a primary. In this case, it was a metastasis. So more nice pictures. This again was an amazing finding. Really, it was really a good spot. This was the axial pictures through the patient, and the radiologist notices a difference. This is the left ureter, and this is the right ureter. He noticed there was a difference. The scan was being done for diverticular disease here. When we reconstructed this is the dilated left ureter, and this here is a solid enhancing mass. This is a ureteric transitional cell cancer. So this is how good CT is. It is amazing. The more you see, the more you look, the more you see. So other types of cancers we do see in kidneys are infiltrative cancers. Now you should notice that this looks different to the previous lumps. It's very hard to decide where is the lump in this. You can see that this kidney is not normal compared to the normal left kidney, but it's very hard to decide where the lump is. It's just all, the anatomy is distorted. There's a bit of something sticking out there. The pelvic fat looks very odd. And then if you look closer, there's something wrong in the middle as well. There's lymph nodes here. So this is the infiltrated renal tumor. This man had a history of bladder cancers for a long, long time. It's been treated for many, many years, bladder cancers. So this is bladder cancer here and here. So we did a total body CT, and we found these as well. These are metastases in his lungs. So infiltrative tumors, most commonly transitional cell cancers. Here's another example of an upper tract transitional cell cancer blocking the ureter, causing left-sided hydronephrosis. And it's extending down the ureter. And this requires a nephrectomy. Although what's worrying here is there's a couple of tiny little nodes here that we don't have to look up. But I think this is quite a recent scan, so this patient's going for nephrectomy. Other infiltrative causes, lymphoma. Metastases can look odd. They don't look like primary renal cell cancers. And infection. And this, I just checked this up because this was bizarre. This is actually a Ewing's sarcoma in a kidney, in a horseshoe kidney. And I just had it in my collection. You just got to show these mad, really rare stuff at times. But this could quite easily be lymphoma. It could quite easily be metastasis. So the other thing that can look like infiltrative or odd is infection. And I wanted to show this because of the urinogram. So here we have a left kidney. This patient attended sick, and there's actually quite a lot of stranding. Just doesn't come across terribly well on this scan, but you can see this kidney's very poor kidney, very thin cortex, very dilated, normal right kidney. So this was a infection. Patient was obviously infected. So we did a renogram. So here's our nuclear medicine renogram on this side, and this is the normal tracing that you get. This is the normal tracing. So you can see the pictures on top, and these are the renographic curves. So the right kidney takes up the isotope, gets to a peak, and then it just ejects it normally. The left kidney is completely flat. There's nothing at all. So we have a differential function here. Basically, this left kidney is not working. It is not functioning. So you could, one option would here would be definitely to remove that kidney. There's no function. And this particular type of renogram was developed by one of our surgeons who's retired recently, Mr. Paddy O'Reilly, who more or less invented the diuresis renogram many years ago. And it's very useful. If this kidney was partially obstructed, it would have the renal curve wouldn't look like this. If there was some function with partial obstruction, the curve would be flat, or even it would go like that. You do not. This is the nice excretory curve that you should get in a normal kidney. So just more usefulness. The CT scanner is a great machinery. This is the bane of urology. Here's a patient who had a emergency cesarean section and came back very unwell. So we did a CT scan, and these are images I've manufactured from the various pictures we took. As you can see in this coronal view, that this kidney isn't functioning very well. This is a normal-looking collecting system, normal-looking ureter. But on this side, it just isn't functioning as well. There's the contrast isn't as well concentrated, and there's a little bit of dilatation, and you can't see the distal ureter. So this is a slightly different slice. And if you look really closely, contrast is entering the uterus. So this patient has a torn right ureter with leak into the uterus, presumably via the cesarean section scar, which is what she had. And in this case, what we did here was we did a nephrostomy. We drained this kidney, let it dry, and we put a stent from the top through and we managed to get it. Fortunately, the ureter wasn't completely severed into the bladder. We let a stent in, and the patient got better, surprisingly. Didn't lose the kidney. Right, so that's CT. So CT is by far the most useful investigative tool we have. We're just doing more and more and more. And we will continue to do more and more because of the improved engineering, the fact that their dose is getting lower and lower. It's now so low. We could certainly our dose in our hospital is less than an IVP, but as I said, my colleague in the hospital nearby, his dose he's using is less than plain film, which is astonishing, but it is true. It is just amazing what is happening with physics and with engineering involved. And I suppose demand, because the machines are so useful, you try your very best to reduce the dose. Otherwise, you'd be irradiating everybody. So moving on now to MR, magnetic resonance. We use a lot of MR for cancer work, especially, particularly cancer work. Our hospital has 2 MR scanners. One is really old. One is not so bad, not so old. It's not. This is the one we have, the better one. Most scanners we use are quite high power, 1.5 Tesla. The best scanners are probably 3 Tesla, but they have a lot of artifactual problems. So for most general hospitals, a 1.5 Tesla scanner is the sweet spot, and you can get very nice pictures from it. We do get asked how it works, and it's a very difficult question to answer because it's really complicated. But effectively, what it has, you've got this is a huge magnet here, really big magnet. It's a huge copper coil in there, and what it does is it resonates the hydrogen atoms inside you, and they all resonate together in little rows like soldiers. And then what you do, you knock them over with a sort of a perpendicular radio wave, which knocks over these hydrogen atoms. It sounds amazing, voodoo medicine, but it is true. And you listen at different times, and these are the various different times. So the effective imaging, there's several different ways of imaging that you can squeeze out of an MR scanner. And I've tried to simplify it by showing basically that you'll hear this concept of T1 imaging, and that's really good for anatomy. T2 is a different list. You listen at a different time. That's really good for pathology. Diffusion sequences are really useful for cancer, but they're pretty horrible to look at, but they're very handy for cancer. And we can also, by maneuvering the various inputs we use, we can suppress fat, we give contrast. We have a lot of different methods of squeezing out information from an MR scan. It takes much longer than a CT to do. You can't really put a sick patient in there, so you can see how do you monitor it. This is such a huge magnet. You can't monitor stuff. Normal monitoring equipment is destroyed by the magnet, or you can't record anything. So it's a very useful machine. It's sort of an outpatient work. Putting a sick patient in an MR scanner is just so hard to do. Very few places can do it. You need a huge backup. You need special equipment. So effectively, it's really, in our case, it's an outpatient tool for investigating cancer patients effectively in urology. I'm just going to show you a few images. So images that we get. This is a prostate, and there's 2 different prostates. This is a different prostate to these ones. So this is what a prostate should look like. This is the transitional zone. and you should have a fairly bright peripheral zone. And the older we get, the brighter the peripheral zone is. This is an abnormal prostate because you've got a bright peripheral zone on this side, then suddenly it goes dark and it looks very odd. This is cancer. And if you look closely, this is the same patient down below. This is the T1 sequence. This is the T2. So the T1 is a bit blander, and the prostate looks the same. You don't get this differentiation. But in this case, it's good for anatomy. It's actually good for bones. There's something wrong with that bone. It's a very different color to this one. This is a bony metastasis, and this is the same patient again. And here we've suppressed the fat. You can see his fat's very dark. We've just tweaked everything to suppress the fat, and this is further tumor here. This is a big lymph node. If you notice, there's nothing on this side comparable to that. So this is a big fat lymph node, and this is extensive nodal tumor from this large prostate malignancy with bony metastasis. So the other of the usefulness of MR, it's fantastic for lots of different stuff. Prostate abscess, you can actually also see fistulas very well with it. It's very good for fistulas, but this is an abscess. It looks completely different to tumor. Very bright. This is the T2 sequence, really bright. This is fluid, really, really bright, very odd. And then giving contrast, the rest of the prostate lights up like a beacon. It's really bright, but you've got fluid which doesn't light up. So this is prostate abscess infection. And this was clearly cancer. Turned out to be really bad prostatitis. Other things we're starting to use MR for now is we're starting to use it as a problem-solving device in bladder cancers. This was a patient that had a distal ureteric, really almost, it was questionable whether this was actually primary bladder or primary ureteric. It was a tumor in the right VUJ, the right cycloureteric junction. And the question was, could it be removed? And on CT, it looked like it could be removed, but it was quite a big tumor. So we decided to do an MR scan instead, just to have a look at the bladder. We could see that this tumor is much bigger than we thought, and it's extending, and it's actually touching the sacrum here. So this is not operable. This will be fixed. So it made a decision for it. So we're starting to use MR in bladder tumors, really as a problem-solving device. And this is what we're doing now. This is our sort of how we're using the MR scanner. It's in prostate cancer. They've just introduced this thing called a best timed pathway, which Banji knows a bit about compared to me. So this is trying to reduce the amount of people dying of prostate cancer in this country. It's pretty high. So the GP does a PSA test. They go direct to MR here. They bypass, effectively, they ring up the urology department, and urology sort out an MR scan. They never see a doctor. So we look at the MR, we discuss this at the MDT if there's something on it. And then we decide what to do about the patient. You do either an image-guided biopsy, or you just continue with PSA assessment or possibly intraval MR. So that's the latest thing we do. I've just a question mark trust here, transrectal ultrasound. We're starting to do less and less trust biopsies. We're doing much more transperineal biopsies. So what we do with the transperineal biopsies is it's a much cleaner technique, but also we do far fewer biopsies because we just don't do template biopsies anymore because we use the images to guide our biopsy. And as a radiologist, I basically draw a map of where I think the cancers are, and the surgeon then biopsies those areas in particular. It's pretty good, actually, this system. It does require a lot of work, however, on our behalf. And I keep getting very rude emails as to wondering why we haven't reported all the scans, and there are lots of them. But it is certainly a good way of reducing the trauma or the death rates for prostate cancer. It just requires a lot of work. The other things we're starting to do, as I said, is bladders. There's been a couple of papers recently about using this as a staging scan because it potentially can stage bladder cancer. Now, so you wouldn't need a deep biopsy with muscle. The problem is it's quite difficult to do. And currently it's a research tool, but they are using it with some success and abandoning a biopsy, just doing a very basic, say a flexible cystoscopic biopsy, and then going to MR, and then going to surgery. That's for the future. I think at the moment we wouldn't do that, but it certainly is, certain things are doing it. Next thing, really good for urethral diverticulate. Absolutely fantastic for this. Completely excludes it or includes it, and it shows the anatomy perfectly for future surgery. We don't use it much in renal cancers. It's a problem solver with difficult cases that we're stuck at on CT. We still can't distinguish an oncocytoma from renal cell cancer. That's just the holy grail, but since the pathologist struggles, I think we'll never be able to do that. The other thing I should have mentioned was fistula. I forgot to say that, but it's really handy for fistula. The also thing, a question mark is pregnancy for colic. You always hear about this. It's really difficult. It's really difficult. I find that impossible, really. I hate looking at this. We occasionally get to do them. I just hate looking at them. I can never see stones. I'm never happy with reporting these. People, certainly there's lots of papers out there saying it's fantastic. I think it's really hard. I'm never quite sure. And when you talk to people at meetings, they're the same. Other people who even people who presented cases, they're all a bit wary. And with the low dose of CT now, if we had to, we'd CT somebody who's pregnant for colic if my hand was forced because of the terrible low dose. So finish with MR. I'll move on to nuclear medicine. I'm not a whole lot on nuclear medicine. I perhaps should have put a bit more. We've got a nuclear medicine department in our unit downstairs from me here, and they're very useful scan. They look at physiology, they look at function. It's very useful. This is a bone scan showing metastasis, prostate cancer. This here is a diuresis renogram. This is quite an interesting scan. I don't know. I'm not sure how well it comes across, but actually this patient has had a cystectomy. If you look at these little images up on top, these little thumbnails, you realize there's a ileal. This is an ileal conduit. The patient, don't forget left, right. The patient is lying flat. You're looking up the way with these. You're looking from their back through them. So this is left kidney, this is right. So this patient has had a cystectomy, ileal conduit, and in this case we're looking for obstruction. It's really quite common. It's a common thing that the left kidney obstructs in these cases. But in this particular patient, he's got very good differential function. It's almost the same. And this is what a normal excretory curve looked like. You can see both kidneys here, the blue and red, both up to a peak, and then they slowly but surely excrete. Really nice example. Just checking time really. The last diagnostic thing I'm going to talk about is PET CT. We don't have one. It's a really expensive machine. It's a positron CT scanner. Positron scanner with the CT stuck onto the end of it. You need some exotic isotopes. The commonest one is choline isotope. However, for urology, that's not great because it's excreted in urine. We're starting to get some access to PSMA, which is prostate-specific antigen, which is quite good for looking up deciding whether something is malignant or not. So in some cases where we don't know if it's malignancy and the patient is having either curative or non-curative treatment, we can try and get a PSMA scan, and the nodes should light up. As we don't have one. Just to show you what they look like, though, this is one recently which we discussed at our MDT from St. Elsewhere's, and they said they sent this to us, God knows why, because this is an adrenal lighting up when it shouldn't. But it turns out this patient had a lung cancer, so he had an adrenal metastasis. So I don't know what we were to do about it, but there you go. That's what a PET CT looks like. I'm pretty much nearly finished. I mean, Banji, do you want me to do anything on intervention? Is he there? He's not. Sure. Anyways, I'll do briefly about intervention. We do a lot of intervention. You don't really need to know about intervention. You need to know something, but you don't need to know how we do it. And these slides just really show the various things we do, from basic to quite complex. Urethrograms, very common. There's the stricture, bulbar urethra, penile urethra. It's commonest at this junction. This is a pretty simple stricture. This requires simple surgical repair. more complex strictures, particularly penile strictures of the penile urethra, are very difficult to sort out and require grafting. They require specialist surgical opinion, specialist surgical treatment. We have one of our surgeons here does these. There's only 2 in Greater Manchester to them for 3 million people. So he's particularly specialized in repairing urethral strictures. But this sort of stricture is a relatively easy procedure to fix. As I said, penile strictures is much more difficult. Or they're really bad, the motorbike accidents and stuff, they can be very bad strictures. So just a thing on renal biopsy, we're doing much more renal biopsies. And the reason we're doing more is because we're doing robotic partials and they want renal biopsies and everything. We've done lots of things. It's quite easy. It's quick to do them on ultrasound, which I do mainly. CT is better, but much more difficult to do in many ways. And it takes much longer. And we use coaxial systems. This just shows you a nephrostomy. It's the same as a biopsy. This is my needle going into a kidney, but a biopsy will be the same. My needle, bit of contrast, wire, dilate up the system, leave it tube in. And this is the latest technique we've done. This is me showing off. This is a reverse nephrostomy. This patient has a conduit, an obstruction, and is obstructing his left ureter from ischemic strictures. So what I've done here is we had a nephrostomy. I put a tube in. I've maneuvered the tube from his kidney down his ureter. You can see the little wire coming out. And I've managed to maneuver that out the conduit into the fresh air. Then put a tube backwards from his conduit up to his kidney. So he's got a little pigtail up there, which is locked, and we leave the tube sticking out into his conduit. It means he doesn't have 2 tubes. He doesn't have a nephrostomy and a conduit. Patients love it. It's actually quite hard to do, but worthwhile. We've got about 5 or 6 patients with these at the moment. And we have to change these every 6 months, which is a bit of a pain. But worth doing. The patients really, really do like it when you do this. This is just an antegrade stent. I'm sure you've probably seen retrograde stents. This is me doing an antegrade. Same system really as you do it, except I have to puncture the kidney percutaneously, and then I push a stent down with pushers. There's my marker telling me where the back of the stent is, and I can leave it nicely. Bladder and kidney. This is our favorite, myself and Mr. Radiology's favorite procedure, PCNLs. Very, very spinal bifida patient, markedly distorted. He's got a stent in which is crusted up because he didn't come back during COVID. He wouldn't come to the hospital. He was too frightened. So what's happened is his stent is crusted up and cannot be removed, and he's got a stone in that kidney, which you can't see. So we did a PCNL for extremely difficult, prone. This is his crusty stent twirled there. This is Mr. Radiology's retrograde, which is injected contrast. This is my needle. I've popped a needle in here into his calyx. This is my catheter and wire down into the ureter. Then I've dilated up the tract with this huge 30 French sheath, which we bent because the ribs got in the way. But we managed to use it. We managed to snare the, if you look at that, there's the stent there, there's the stent there. And if you look here, where's the stent? Well, the stent is gone. We've managed to remove the stent. And this is Mr. Radiology with his cystoscope, using a cystoscope down his tube. He removed the stone. And just to show you that, we also did supine that was prone. This is a mini PCNL with a metal, with a 17.5 French metal tube, much smaller and much less traumatic. We've never had, touchwood, never had a bleeder from this procedure. This is really safe. Makes a very small hole. So for smaller stones, we can use this. I just put this in, but I don't do this. Renal tumor ablation using freezing or burning them, becoming popular. It's very difficult to do because you need 2 hours inside a CT scanner with a GA, but this microwave technique is brand new and it doesn't require GA. So we hopefully will get this service soon. But at the moment, it's a GA and 2 hours inside a CT scanner. So very few centers can do this. And also because we have a robot here, they do laparoscopic partial, and they do robotic partials. So we don't have the same need for it as other hospitals. And the last thing I mentioned was angiography, because we used to do this, don't do it either. Really only for PCNL, bleeding after PCNL. We've had 1 bleeder in the last 10 years. Treatment of benign prostatic hypertrophy. Yeah, it's in the armory of treatment. It does work for some, it doesn't work for others. It's actually very hard to do. So you need a very specialized radiologist to do it. It's quite tricky. Assessment of stenosis, and you see my question mark here. Some people don't like, if they've got a big tumor. In the past, was traditional to obstruct the vascular supply and reduce blood loss, but actually, most people don't like that now. They're happy not to do it. And that's the end of my talk, really. And this is me. This is the usual radiology complaint. Right. What do you think of that? Any questions? Any questions?
Yeah, any questions? That's absolutely
Yeah.
wonderful, Neil. And I can empathize with that last picture.
Yes.
Because I can see my radiologist think, not you again.
Mm.
Now, that was wonderful. Any questions from the, can you just unshare your screen so we can see faces? So if you go to the top.
Yeah, hang on a sec. Oh, blast.
Oh, I think I can actually do that for you.
Can you do that? Yeah, there we go.
There we go.
Yeah.
Okay. But while they're all thinking about what to ask, a few questions I could probably ask you. I'm obviously quite surprised at your suggestion now that you have CT scans that give less radiation than the plain abdo X-ray, which is phenomenal.
It's amazing. There's one of my colleagues works in the small hospital Crewe, quite close to here.
Yeah.
But he's a physicist, and they've just got a brand new machine, and he's worked with the company using artificial intelligence, and he's written a paper just recently. It's only came out a couple of weeks ago, and everybody was, wow, it's amazing. And it is, the pictures he's shown are fine. They're not the world's best pictures, but they're pretty good. They're diagnostic, and the dose is incredibly low. With our new machines, we are reducing. We can't do that yet, but we have, as I said, we have a brand new machine, and hopefully we'll be able to get that dose down at the same as his. But our current CT scanners, a CT KUB is less than an IVP, definitely, with our current machines. So
because we have two groups of patients that we still struggle with about pregnant women, and also children.
Yeah.
And do you think sometimes we tend to go for MRI scans, particularly in pregnant women, when we're thinking, has she got appendicitis or not?
Exactly,
do you think we're ever going to get to a stage where CT will be safe for those two groups of people?
Well, yes, I think we probably will, because first of all, the radiation risk is probably exaggerated, but it's because it's the radiation risk has always been an extrapolation. It's never been proven that radiology cause tumors, but we just assume it does because radiation does affect you. And there have been there was a great paper from America where somebody got the dose wrong somebody made a mistake with a CT scanner, and they were doing angiographic assessment of the circle of Willis, and all these people turned up having lost a ring of hair.
Oh, I see.
Yeah, so it does, radiation is definitely there. But certainly, I think with this recent paper, it only came out in March. I think it's going to be a bit of a game changer, because we would do CT more readily. I certainly think that most of the new machines are really good at reducing the dose, really good. The more modern CT scanners, they are really, really good. Certainly are. We're in the middle of replacing quite a few of ours which have fallen apart, and our new machines can reduce the dose by at least 25% to our previous machines. So we've just got one replacement machine, and we're getting this brand new machine which is just being installed, and the replacement machine, which is a very basic machine, has a 25% less dose than the one it replaced. So yeah, the dose is really coming down. It's almost down to plain films. So you could argue, well, why not do a CT scan on a pregnant lady if the dose is the same as a plain film?
Yeah, I think that's something that one needs to look into. The other part that you obviously raised was the fact of, obviously, Banji has already told you I'm a colorectal surgeon, so what do I know about urology? But you did say they don't do a lot of endorectal ultrasounds now for prostate cancer. No, we do. We're definitely stopping the Banji will tell you more, but the trust is definitely dropping, and partly because the MR is showing us exactly where the tumors are. So we're getting quite a few anterior tumors, which
which are unreliable on a truss. The tumors in the anterior gland you often miss. So we're still doing trusses, but we've definitely reduced the number, and we're doing much more transperineal. One of Banji's colleagues, well, two of his colleagues, doing quite a lot of transperineal biopsies now, in preference to trusses. Also, the patients actually prefer it. They're now starting to do transperineal, local anesthetic transperineal biopsies. It was GA for transperineal, but now they're doing them under local and sedation, same as for truss, and it isn't as painful apparently.
Okay.
I don't know. I haven't had a truss, so I can't tell you that, but it isn't as painful apparently, and it's definitely a better biopsy technique. There's less infection rates, and it's more accurate. We're getting better biopsy results than we were from trusses. The hit rate's better, definitely is better. It's very good now.
Good.
Thanks, Neil. One question from the residents I've just picked up. They wanted you to elaborate on the use of frusemide with contrast CT, how it works and why it works.
I tell you, I first heard about it from a crazy French radiologist at a meeting about 15 years ago. And what it does is it does two things. What we do is we do a plain CT, and then we give the patient contrast and frusemide and get them to walk around the room a bit. And about 10 minutes after that, we scan them again. And at which stage the frusemide's working, the contrast is going through the patient. So instead of having, if you didn't give contrast, what would happen was you'd only have contrast in different bits of the kidney. So you might have contrast, if you did an early scan, you'd have contrast in the cortex. If you did a scan a bit later, you might have contrast in the collecting system, but then you wouldn't have contrast in the ureters, and you wouldn't have contrast in the bladder. So by giving the patient frusemide, you get contrast everywhere. The kidneys go into, you get them whizzing along at 100 miles an hour. The contrast whizzes through. We also do fiddle about with how much. We can also give 2 doses of contrast. We can split the contrast, give some contrast early, give some contrast late, in an attempt to get contrast throughout the system. So we have contrast in the cortex, contrast in the renal collecting system, contrast in the ureter, and contrast in the bladder. So that's why we use frusemide. And the other thing it does is it dilutes the contrast. And that can be really handy, as you've seen with stones. Because your average stone is about 400 HU. So is contrast when you scan it, 400 Hounsfield units. That's the measurement of density on the CT scanner. If you give frusemide, the contrast goes down to about 150 Hounsfield units. So you can see stone through contrast. So it's really handy then for planning a percutaneous nephrolithotomy, because it will show you the anatomy of the collecting system and the stones at the same time. And you can plan which calyx you want to hit. Is it possible to do, should we do this prone, should we do it supine? What's the best method of access into the collecting system? That's why we use it. It's some places just use dual bolus systems, but we find we prefer frusemide because of the diluting effect is really handy as well. So it's made a big difference to our system. And it also reduces the amount of scans we did. If you look at the original papers, they did a CT KUB, they did a CT early CT, they did a middle CT, they did a late CT. They were doing 4 or 5 sequences, 4 or 5 runs of CT, and the patient was getting a huge dose of radiation. So now by using frusemide, we've got it down to a pre-contrast and a post-contrast. With the new scanner, we'll just do a post-contrast, because our new dual energy machine, I'll be able to subtract one energy from the other and create a non-contrast, and imagine we can create a non-contrast scan. Almost, it's magic. I mean, it's complex physics. I'm not quite sure how it works. I was never that good at physics when I was in school, but there you go. So yeah, the frusemide is very useful.
A bit of pathway question. I can see that you're doing some straight-to tests from PSAs. Has that overwhelmed? Because in colorectal, we did for colonoscopy, and it's overwhelming a system. Yeah. Does it overwhelm your system?
I think the reason it doesn't overwhelm the system is because we've got some very interested uroradiologists. on Friday, I get a bunch of emails demanding to know why I haven't reported 4 or 5 MR scans. And I write back and say, because I report MR scans on Monday. So, it's just, it is really difficult. We're really struggling. And one of my colleagues has been off ill recently. So there's only 2 of us doing the prostates, and it's a struggle. We're just about managing it. And we're pretty well got. We've a lot of radiologists. For our hospital, we've 15 radiologists. So we're a big unit, and we're struggling. We struggle, but we can just about manage. The problem at the moment is it's holiday season here, and it's hard at the moment. I'm doing it on my own next week. I'm doing all the prostates. I'm doing all the MDTs, and you get a bit shirty and annoyed.
Yeah, I can imagine.
It is difficult. We're just keeping our head above water. It's been a big increase in the amount of scans done.
Yeah, I can imagine.
It really has.
Okay, any more questions from the floor? Okay, no. Oh, sorry. Did I just see something? Oh, yeah, something's just come up. Which is the best radiological investigation for staging abdominal tumors? I'm not quite sure. It's put in bracket urological GI tumors.
Always. I mean, the problem you've got is we have as well. We get a lot of patients coming through A&E, and they have they have a general CT scan, and we find a tumor on it. And what happens very often is we have to go back and do a specialized CT to work out what the tumor is. But that's so your average. So we have a sort of a general purpose scan, a fairly basic CT abdomen and pelvis. We tend to just give. We just give. They come through. The typical case, they come through A&E, panic in A&E. The patient's got pain, etc. They have no idea what's wrong. They get a CT. We will just do a CT with intravenous contrast, and depending on that, we may do nothing, or we may go on to a more complicated investigation. So we use the simple, basic post-contrast CT scan almost as a sort of routine, and as a sort of a window into further investigations. For example, in appendicitis, it's very easy. Bang, appendicitis is an easy diagnosis to make on CT. You don't need anything else. You just need a basic scan. But for some of the colorectal stuff, yeah, you'd have to go and you wind up doing further. But it does give you a path. It gives you some idea of what to do next. You may go on to stage differently, do different scans, maybe do MR or whatever. But a basic post-contrast, post-intravenous contrast scan, that's what we tend to do from the A&E side of things. They drive us mad, by the way. There's so many. And on some patients, completely inappropriate, incredibly elderly patients, and you think, well, you can't do anything for this patient. Why are you getting a scan? And they just look at you and say, oh, because the patient's something wrong with the patient. They haven't actually thought anything through. That's why we like dealing with surgeons, because the surgeons know exactly how if this patient is ever going to hit the surgical table. Because if they're not going to hit the surgical table, they won't investigate. Isn't that right, Banj? You quite often don't investigate.
You're very right. I'm really very grateful, Neil, for the time you've taken to speak to us. One thing I certainly wanted to take the opportunity to highlight is certainly modern or contemporary urology cannot exist without a very good, strong urology support, which is why we appreciate you so much. And if I can make no further emphasis, it's how strong and important that link and how strong and important that relationship can and should be to be maintained, to be cultivated while one is trying to look after patients. I suppose that's perhaps the most important thing I wanted to emphasize to the residents today, especially for urology. I'm sure it's the same in general surgery, but certainly I can speak for urology that link is invaluable and it's essential.
I think as I said before, we really do have much closer links with surgeons than we have with physicians. I think it's because we're sort of interdependent on each other in many ways, and also some of the procedures we do. And I do quite a bit of colorectal intervention and gastric intervention because I do intervention. So for example, colonic stents.
Yeah.
You know, I do those with the surgeon as a combined procedure, and it's such a difficult thing to organize. You wind up knowing the surgeons really well, and they tend to be they know exactly what you want, and you know what they want. So we do have close links there. Well, of course, I mean, I trained in the same hospital as Banji did in Dublin, and there was fantastic links between the radiologists and the urologists in the Meath Hospital in Dublin when I was there 30 years ago. They and that's where I learned it really. There was a couple of very good radiologists who were great mentors in many ways. Banji will remember them. Well, I'll remember Jerry Hurley anyway.
Yes,
So,
yes, I do. Yes, I do.
So we try and keep the same here. So but generally it is the same, isn't it? Generally, we'd be the busy. We are the busiest centre in Manchester, Banji, aren't we? We are really in urology.
We're the busiest urology department in Greater Manchester. Yeah, that's correct.
So we'd have the most cases. We have three consultants, radiologists doing radiology, which is quite a lot compared to most hospitals. Most will have one or two, and I'm not sure how they manage when they're on holidays and stuff. I don't know how they do it. It's a struggle.
Okay, Neil, thank you very much. Thank you for the great lecture, and we're very grateful for that.
Thank you for inviting me. Much appreciated.
Thank you very much.
Thanks, Neil.
Well, I was forced to.
One day we'll still get you to Lagos or Ibadan. One day, perhaps.
Yeah, God knows. I'll bring my golf.
We've been talking about it for many years.
I'll bring my golf clubs, Banji. As I said, my father was examined in Nigeria. My dad examined in Nigeria in the 1980s in psychiatry. He was a psychiatrist. But I'm not sure which university it was. It wasn't Lagos, but it was because one of your ministers embezzled £8 billion, and he was caught in London, and the English wouldn't let him go. So instead of getting the English doctors to review final med, they got Irish doctors to do it instead. So that was a while ago, wasn't it?
Yeah, that was quite a while.
Yeah, so that was my dad did. He was in Nigeria, and I'm not sure which, but I don't know which university he was in. It wasn't Lagos. It was one of the medical schools in Nigeria many years ago.
No, that's very good. And that's very good, Neil. Thank you very much, and hope we'll see you sometime soon.
Radio, thank you very much for asking me again. Okay.
Okay.
Cheers.
Bye.
Okay.
Good evening to you, doctors. Thanks, Funsho.
Yeah, thank you very much, Banji. Thank you very much for organizing this as well, Banji. Okay, so I'll talk to you guys all. And for everybody else, I'll put the feedback form online in the next 5 minutes, and I'll send you an email when it's online. Thank you.